So, as you rightly pointed out, hypothesis. We can only just imagine what it could possibly be contributing to.
Be a singer.
A singer. Okay. So, the unusual excessive flattening could very well be at the basis of the collagen arrangements to begin with. Hypothesis 1. That could be the influence of the mechanobiological feedback, okay? The second one could be the individual's immune reaction, and the contralateral feedback could be the second hypothesis. The third one obviously would be the genetic one. So we do have 3 hypotheses. All of them could be feeding one onto each other, but we could not be able to delineate at this point of time.
I have seen like
Could
late
it be
flattening in, I'm sorry, I just say, just because it may, late flattening can be observed after many corneal conditions, interstitial keratitis, sometimes DLK, post-LASIK. You have flattening over time, which may be due to stromal remodeling, like scar effect, epithelial atrophy, etc. So it's not specific to cross-linking that a cornea inflammation after an infection, an abscess, tend to flatten over time. I've seen that many times, especially interstitial keratitis.
Could it also be that this excessive haze gives an artifactual impression of flattening, which is actually not
But that's
so
what haze itself. I used the word the bad haze. Bad haze, bad flattening. Good haze, good flattening keeps happening all the time. But the bad haze and the bad flattening is something which has happened, which is different in that particular individual, like one or two cases we see. And for that, the question is, Himanshu, what do you do for this flattening? Do you think as a cornea surgeon, do you think that anything you do to stop this from flattening?
So first and foremost, I don't know the cause, so it may not be easy for me to hold on to that can I stop that flattening. So the important thing, what I would do as a cornea surgeon, I would wait before doing any visual.
But Himanshu, the question is, if we are waiting, it's flattening more and more.
Sure,
It
sure.
does. And the patient is meanwhile is hyperopic.
So what do you
although he
do?
was
That's
myopic.
the challenge.
No, I don't think we have. So I would intervene where I have a definite idea about pathogenesis or pathology of that particular disease, and possibly I can treat that and I can stop that. If I
So
don't
one minute,
have,
Himanshu,
I'll
you
be
can ask anybody in this audience have seen this excessive flattening over time. If you can raise your hands.
It does not occur anymore with the accelerated cross-linking.
But
Only the older
question,
Ma'am must have, Dr. Namrata must have seen a lot of varieties.
I agree with you that it occurs less with the accelerated collagen cross-linking than with the Dresden protocol, because it is there in some of our cases which were done before, where we were doing more of Dresden protocol than with accelerated.
You agree, sir? You agree?
No, I agree. Maybe we are doing too much in the Dresden protocol compared. But at
So
that
you
time
ask if they are.
but at that time when we inaugurated that that kind of parameters, we just wanted to go for an optimal effect, and maybe that is too much after all.
So maybe you ask them to rub more,
So the
that
treatment is rubbing of the
they
eye.
don't flatten and they.
No, this is something interesting which Arka pointed me out here. You can probably answer. He says, this explains why it used to happen with your Dresden and it don't happen now, is because Dresden used to cause more death of keratocytes and more stronger demarcation line and more death of keratocytes and more remodeling of keratocytes will make your healing or your immune thing different, right?
So at your demarcation line, you have the keratocytes that have migrated there. So these are now activated keratocytes. They are myofibroblasts, which are laying down collagen. Now, if they are not controlled, they'll continue to lay down collagen, and that's the reason why it's becoming more and more flattened, because it's now
I mean, that is a good explanation, because it's more to do with how many keratocytes
essentially scarring.
you kill.
You're inducing scarring, which is going beyond what your required
also
needs are.
to support that part, we know that the keratocyte population is different anteriorly, middle and posteriorly. The way they behave is also different. So when we go accelerated cross-linking, when the treatment becomes more and more superficial, the way cornea is going to behave would be different. So yeah, I agree.
Right. So to
Damien.
answer your question on if you can control it, so maybe something that can control the growth factors that are associated.
This photo courtesy is from Farad. He just took it and he added it and he just gave it to us.
It goes to the internet. Is that correct?
You just did it now.
This is a very nice example of a
I
fake
think
news
you can,
from the media.
Yeah, we can
Typical,
misuse
typical.
it everywhere. Put it all over the social media.
Yeah,
and we can misuse
we're going
the
to flood it
photograph.
with social media now. And I will take the credit
Fake
of
news!
and you have my badge for it's going to be etched in history forever.
So, Rohit, if I may ask both Professor Theo Seiler and Farhad, both, that what is the good outcome of cross-linking you would consider if you do not have any flattening, but if the progression stops, is it still a success?
I think that's the definition, the original definition of success. Nobody promised the flattening. I think this was rather something unexpected in the early
So
years.
any protocol which stops the progression but does not have significant flattening, you would still call it success?
I would.
Yeah, the same with me, because most of those patients wear on contact lenses when they are coming in, maybe not in your country, but in my country, they do have form stable or rigid contact lenses, and they recognize that it's getting worse and worse. They had to change the lenses. And now, if we tell them, hey, now we stopped it, and you can continue with your contact lenses, which they can better because they have less corneal sensitivity. Now, if you can continue with the contact lenses, then you don't have to be afraid that the sword of Damocles is hitting you right away. That is a successful procedure.
So my next question would be, if that means that the stopping progression is success, that means when we have flattening, that's a little overkill. So why can't we have a procedure where we reduce the energy to the level where it does not show flattening, but it stops progression? So that means whatever energy we are using, it's still high when we still see flattening post-operatively.
I think this is just what you mentioned, Theo, 5 minutes ago, that maybe the 5.4 joule might be too much in certain cases, maybe too little in others.
Even the current protocol we use, when we see flattening, that's overkill.
The future, according to what I understand, what Himanshu is saying is, if you create a cross-linking machine, which Himanshu believes is his dream machine, that machine should give you enough fluence, which does not cause death of keratocytes, but it does not cause any collateral damage, but it should cause a cross-linking effect. I think that is something Mukesh was working on with a different dye, which I can discuss it a little later. So if we move to the last part of this, we have 15 more minutes, and this comes to Professor John Marshall, Natasha, and Arka about the genetics of cross-linking, which is probably the most important thing, which is the least understood part, because genetics of cross-linking, genetics of keratoconus and its impact on cross-linking is very important. I mean, you have a huge genetic variation in them, and the reason why they flatten excess, Himanshu, could be that they may have a different mutation of one of these genes, which may make them to lay down a different collagen. So when you have a collagen, when you have an abnormal reaction to your cross-linking, I've had genetic tests done on some of my patients. When they have a genetic abnormality, their cross-linking behavior and moods are completely different.
Certainly possible, absolutely.
You know, I've had patients with more infections. I've had patients with more sterile infiltrates. I have patients who behave with excessive flattening. I have patients who do not behave to cross-linking. The question is, the previous slide was about the known genetic markers. No, you don't need this. Known genetic markers of cross-linking, of keratoconus. So the question here is, I'm sure yesterday you mentioned that you have figured out 64.
It's
54.
The problem with genetic diagnosis at the moment is it's extremely easy if you have a single gene mutation causing a disease.
Yes.
So for example, in the corneal granular dystrophies, you have 5 different dystrophies, all caused by different specific mutations on the long arm of chromosome 5. Very, very easy. you can design a genetic diagnostic technique from a buccal swab, which will give you 100% diagnosis, absolutely accurate. Either you don't have the disease or you do have the disease. The problem in multifactorial diseases, such as keratoconus, is that at the moment, all the studies show a huge range of potential genetic defects that are correlated, not causal necessarily, but correlated. And we started with this relatively simple list of about 27 mutations. I think we're now up to 62 mutations. And what we've done there is to develop a risk analysis function. So depending on how many of these potential defects an individual patient has, you can give them a risk score. It's not absolute, but it's an indicator which may help in the
It's like building a panel there. It's like building a gene panel for keratoconus. Do you think it's going to come, genetic panel, that you take the blood?
What he's saying that number of gene, more than number of gene,
exactly.
he has the risk score that if 3 gene, 4 gene, what
Right,
is the risk?
exactly.
So
It's like a fingerprint
higher
of the
risk
disease.
score, the greater the risk for you as a patient. And the evidence at the moment is that we do have a number of familial studies where it's relatively clear and we can identify the genes. In population studies, it's more difficult, but there will be a keratoconic therapeutic test for Asian eyes introduced shortly, which will give a risk factor, and that will be produced commercially.
Yes, Farad?
Rohit, I think, and the whole team, I think you're absolutely on the right track. If we compare this to retina 20 years ago, retinitis pigmentosa, 2 major areas of problems, either point mutation in the rhodopsin gene or mutations in the CGMP phosphodiesterase, and every single subtype, more than 200, has a different phenotype. And I think we will have different phenotypes in keratoconus onset, in keratoconus severity of progression, and knowing which genotype is responsible will influence our clinical decision-making tree. The only reason we are not doing it yet is because the testing is time-consuming and expensive, but we also know that in 10 years it'll be inexpensive to do, and then we are absolutely on the right track here.
I want to ask a very crazy question for you. Imagine of all this gene mutation, a patient has one of the mutations and you do a cross-linking. Say, let's pick up the TGF-beta 1 mutation. Do you think that after you do a cross-linking, if the TGF-beta 1 mutation or the FOX1 mutation will give you the same effect of cross-linking like now? What do you think will happen? I'm just picking up one gene. I'm picking up this one. I mean, this is very important for all of us here because we have to understand that at this point of time, we don't know that is the genes, but we are made up of genetic material, and we have to understand that today or tomorrow, this will be the mainstream of how you are going to understand a disease. For example, if this patient has this mutation and Wnt1 mutation, how do you think post-cross-linking the patient would behave? Yes, sir.
Well, that comes out of the matrix analysis, and
now just for the sake of discussion, let's assume he has this matrix.
You can't. We don't have enough data to do specific defects at the present time. What we're dealing with is the whole group of defects and saying, okay, well, if you have these 6 or these 12, you're at a much higher risk than either the normal population or any one of these individual mutations.
Right, so to connect it, so what you can have is the risk scores assigned to a certain gene or a certain mutation that may be broken down further as to those in whom cross-linking would work or wouldn't work, or those who would have greater progression or lesser progression from amongst the variants that we find. But the problem that he pointed out very rightly is that in the population scale, the familial mutations that we typically find, their prevalences are so low that we are it's very difficult to predict.
No, Arka, what I'm trying to say for clinician is, at this point of time is, if you have one of the mutations in a patient you don't know, they may behave differently to your cross-linking. Are we right on this?
Absolutely.
So if you have a reaction, or if you have something, or a healing, or a scarring, which may be not according to your normal way of how it happens, you may have to keep in mind that he may be having a genetic variation. What I do in these patients is, just to complete, then I will give the mic to you, I call the parents. And I do the test on the parents, the topography maps on the parents. It's a very, very early surrogate marker. It gives me an idea that if the parents have a very suspicious topography and the child has a keratoconus, and these are the patients who always have something which is genetic. Do you agree to this?
Yeah, I have an important observation here. Is the TGF beta here is as you know is heavily involved in Marfan syndrome. So the point is, if you have a soft tissue, again, that's very important, because I think we were misled in keratoconus. This TGF beta produces collagen weakening because of the fibrillin cannot bind the protein. You know that. You have aorta ectasia. You can lose the joints, etc.
Aneurysms.
But if you have a soft cornea, and the Marfan syndrome is this, it's keratoconus as we think it should be, or it could be. In Marfan syndrome, again, the cornea phenotype goes the opposite direction to keratoconus. Of course, it gets flatter because the IOP stretches progressively collagen. But it gets flatter because as the sclera inflates, the cornea flattens because its radius of curvature increases. So this is very important. It is critical in the understanding of keratoconus that you must get rid of the idea that a soft cornea becomes a keratoconus cornea. It's wrong. A soft cornea, which is not traumatized, becomes a thin, flat, stretched cornea, not a conus cornea. This is critical. Keratoconus is focal. Now, I take all the explanation you like about this focality, but to me, the first thing, as a naive, observant clinician, is that when you have up to 92% of prevalence of eye rubbing, and eye rubbing exerts directly on the eye, when you have all these cases of unilateral keratoconus caused by eye rubbing on one eye, etc., all this monozygotic discrepancy. Monozygotic accordance doesn't mean it's genetic. Flu can affect two monozygotic twins, but there are cases published of monozygotic discrepancy.
You believe it's genetic?
Huh?
You feel that it could be hugely genetic variation in them?
No, there's genetic risk factor for allergy, for
just
thin
nature
cornea.
and nurture.
But a soft cornea does not mean keratoconus. That's my point.
He wants to speak something.
I just think if you look at what's happened in terms of the retina, and now most eye hospitals in UK have genetic screening for inherited retinal dystrophies, that's the diagnosis, not the clinician with a slit lamp and a lens. So genetic diagnosis is really important. That's why we are discussing a collaborative effort, and that's why we would like to give our screening technique to you. As soon as it's introduced, it will give high risk, medium risk, low risk, but we need to develop it further together.
And you believe that? Do you do any genetic testing for your keratoconus?
I've been working on retina for almost 10 years, so I'm familiar with the phenotype-genotype correlation. Yes, we are looking into some of them without disclosing too much.
The future,
Wait.
I
do have some homework for you. I mean, you got this list, or you can get this list from patients with keratoconus.
Right.
Why don't you ask other patients who have no keratoconus and do the investigation for rubbing? So maybe rubbers have similar ones.
A genetic risk score for eye rubbing.
Then he is right.
That's exactly what we're doing.
So if you go for those defects, and some of them are really rubbing inducing because they have
what we believe is if you take in patient with allergy, with astigmatism, and they rub the eyes, their genetic marker will not be the same as the keratoconus marker who have allergy but rub the eyes and get the keratoconus. So rubbing along with your genetically differential marker is what may be
has a different spectrum.
Exactly.
Okay.
That's a different spectrum. So for example, if you take a 20-year-old girl or boy with allergy who rubs the eyes, and he has a symmetrical astigmatism, and you have a 20-year-old girl with allergy, no allergy, but rubs the eye, but has a keratoconus, it means that there is an inherent functional defect of one of these genes there which we don't know. For that, we had to have thousands of people with allergy, with eye rubbing, no keratoconus, and this is, I think, the way, and the best way, a very simple way to look at it is, what I have done is, in this group is, I always look at the family topographies of children who rub the eyes with allergy and no keratoconus, and the family topographies always picks up the scent.
So in fact, we have now huge data of cases where allergic eye disease, absolute keratoconus, and normal patient, and we will be publishing soon, and we have found that again, if you look at naked eye on topography, you may not see change, but when you run AI, you find out distinct features of those allergic patients, those eye rubbers. They are not normal topographer and they are not keratoconic. There's a different entity which lies there in front of. And with AI, Abhijit, you can put some inputs here.
I think we'll do it in the next
Sure.
session.
Let me just come because this is a very huge thing, and it's a huge data which we are going to come out with.
So the future, whether we see it or not in our lifetime, but at some point of time, the treatment is going to be a gene therapy based approach. Maybe in 10 years, 20 years, 30 years. Do you envision that, both of you, being in this domain?
Yeah, definitely. And the gene therapy may be mutation independent, as is the case for a lot of the multifactorial diseases. So, so for some of these genes that we know, which we and other groups around the world have shown to be associated with the progression, associated with outcomes of collagen cross-linking, those could potentially be used for gene therapy.
Abhijit, do you have it quickly ready, or we want to do it later? Quickly. We have just a minute.
But if you just think for a moment, DNA structure was described and published in Nature in 1953. In 2003, we had the human genome, so the whole book of man. So in 50 years, genetics, complete revolution. And the eye is at the forefront. The first eye genes were discovered by Shomi Bhattacharya in 81 too. And we're pushing, and the first gene therapies really came in after the failure of the people. So gene therapy, well, first of all, personalized medicine has become ever more important, especially in cancer, where people are looking both at the genetics and the immunology. Secondly, the speed is moving very quickly. The techniques are becoming much faster and less cost. So I think there's a huge future. We're not quite there yet, but we're approaching it.
So maybe, yeah, quickly, Abhijit.
So just to add on to what Dr. Himanshu said, he's perfectly right. With allergic eye disease, if you just look at the topographies of the corneas, and it's absolutely impossible to detect those fine features with the naked eye. And gradually we are seeing that the role of AI is going to become more and more in diagnostic applications. So hopefully next year we'll have a full-fledged study and probably a tool to show to you how you can distinguish between an allergic eye disease cornea versus a keratoconic cornea. And just a minor comment to what Damien mentioned, that 5 microns will give a diopter. That's not going to happen. So if that's the case, why in refractive surgeries, when you do, let's say, LASIK or SMILE, you remove 10 to 15 microns of tissue for 1 diopter? Why is that the case?
Oh, because you have to look back at the relation between curvature and elevation on a specific zone. Keratometry is measured in a 3 central millimeter zone. So if you apply the Murnerian rules, like the depth of ablation relating to the change in the dioptric power of the cornea, you'll find that 5 microns on the 3 millimeter zone is enough to change 1 diopter. Do the math, and no, it is.
I think both of you can do the math. for the lunch time, so we'll move to the next session.
So I think epithelial,
have a small
I think epithelial wound healing explains what we see mostly after cross-linking, because remember that in the first 3 months, the cornea is steeper as measured in the studies, and then it flattens. Why is it steeper? Because you remove epithelium. The Bowman's membrane is published, is steeper than the epithelial surface in normal cornea and even more in keratoconus patient. So you remove epithelium, there's a first phase of cell migration which does not really smooth out the defect, so it's steeper, and then over time, hyperplasia makes the cornea flatter. I'm not sure that's the right explanation, but it's plausible, and it should be investigated with epithelial OCT we have now. So my prediction is that if you do monitor your patient after cross-linking, you'll see that the explanation of this flattening takes place in the epithelial maybe way before than in a stroma. That's my assumption.
I have a question which is more for Dr. Damien. If you, according to you, the mechanical forces are the main cause for deformation and keratoconus, why can't the treatment be oriented towards a mechanical, like a right kind of massage?
Stopping rubbing is stopping the mechanical force.
Yeah, but why can't it be corrected by a similar or the right kind of mechanical forces?
But you can't. But that's what he said. I don't know whether you what he said is, you don't, even if you want to rub the eyes, if you instead of stopping, it's like you ask somebody to stop alcohol, instead of asking him to stop the whole bottle one day, you ask him to drink slowly, so that at some point of time you do a withdrawal. He says that instead of doing this, you can try doing this. So that's the exact way of how you change the mechanical force.
Yes, but has that brought about a flattening?
Pardon?
Why is that not bringing about a flattening?
Disease, he says, when you stop rubbing, why is it not bringing flattening? Because the disease stops, but it's not going to reverse it. I've answered your question.
Why is it flattening when you stop rubbing?
Why is it not flattening when you stop rubbing? Why is it only stabilizing?
I mean, if you break your pen, why your pen does not go back to its initial shape? Because entropy in nature cannot really make the increased deformation going to the more organized thing. Once you have the slippage of the fibers in the cornea, once you have created a focal weakness which creates the buckling of the keratoconus, how would you expect the cornea to go back in its original shape? Like if you break a glass, the glass is broken, but of course it's a living tissue. So it's covered by the epithelial surface, which, as we know, is a nice shape modulator. So when you stop rubbing, you have less cytokine induced by all these molecules go lower. Hyperplasia can occur again, and again, we'll do the math at the pose. 5 microns in the center are enough to change the keratometric readings by 1 diopter, and then it may explain this kind of keratometric fluctuation. Plus, and that's documented, and we hope we can publish this, when patients sleep like this, it's like warpage, contact lens-induced warpage. Orthokeratology, It's just the pressure of the eyelid on the rigid hard lens at night. It can correct 5 diopters of myopia just by the sole pressure and the shape which molds the epithelial. Now, suppose you have 14 kilograms this is the weight of the head, on your cornea for 7 hours. Won't you expect that this may change the cornea shape? And won't you accept that when you release that 14 kilogram force on your cornea, the cornea shape may go back to another equilibrium shape? That's just physics. It's like easy concepts. It's way easier than these things. But it should be tried first. They want to stop. Okay.
I think we finished the first session now. Thank you, Damien. You've been great as usual. And all my co-debaters, thanks a lot.